All right, welcome to the Long COVID and Post-Infectious Syndromes Echo. This is a collaborative effort between the University of Utah and Bateman Horne Center. If you're joining us for the first time, we're happy to have you here. And if you're returning, welcome back. I'm Clayton Powers. I'm a full-time physical therapist at the University of Utah and also education liaison for Bateman Horne Center. Today, we're privileged to have Dr. Melanie Hoppers, a board certified physician trained in pediatrics and internal medicine, presenting to us on long COVID in children. This will be the first part of a two-part session on pediatric care. So please plan to attend the second session on December 2nd. And Dr. Hoppers has both professional and personal experience caring for children with ME/CFS. So, Dr. Hoppers, the time is yours.
So, yes, I am a physician. I see kids and adults. My learning began 11 years ago when my 10-year-old developed mono and never recovered. She has moderate to severe ME/CFS, and so a lot of my knowledge comes from this, from living with it. I hope none of you have, I hope that no one has that experience, but unfortunately, many of our children do. So I'm from the Bateman Horne Center. I'm very grateful for them. We are a 501(c)(3) nonprofit organization focusing upon clinical care, research, and education regarding infection-associated chronic conditions that include myalgic encephalomyelitis, long COVID, and their comorbidities. We do have patient cases. They have given informed consent, or they are a compilation of people that for us to share information. I have no disclosures to discuss and no financial benefit or gain to be had from anything I talk about today. So first, I just want to mention I've included some art from young adults and children who have wanted to express themselves in what they have created. And I just want to share this along the way. So this talk's kind of hard because I know we've been doing an echo series for adults. So um, a lot of this is review. I will try to make the review brief, but I'm really hopeful that there are pediatric providers that might be tuning in perhaps for the first time. So I don't want to skip too much. And if I'm too brief for you, slides are available, resources are available. Additionally, there's QR codes all through this talk, but at the end I have two that has everything on it. So if you want to wait to that, it might be easier for you. So long COVID now affects more children than what used to be the most common chronic illness in childhood, which was asthma. Um, the prevalence of long COVID in children is there are thought to be 5.8 million children affected. About 5 million children are affected with asthma, unfortunately. Yet, while providers readily diagnose and treat asthma using the established evidence-based guidelines, they often miss or dismiss long COVID entirely. Without these evidence-based guidelines, many providers feel uncomfortable managing a condition they don't understand. I can understand that. This leaves millions of children, however, without appropriate care. My goal today is to give you confidence that there are viable tools and approaches available to help these children that are safe. Long COVID, as defined by the National Academy of Science, Engineering, and Medicine, is an infection-associated chronic condition following a SARS-CoV-2 infection. It persists for at least 3 months in a continuous relapsing remitting or progressive disease state. It affects one or more organ systems and presents with single or multiple symptoms. In other words, it's all over the place. The broad definition captures the heterogeneous nature that we do see clinically. Long COVID can follow a mild infection or a severe infection. It's more common after severe infections, but we see many more mild. Additionally, it can occur after an asymptomatic infection. This can certainly be problematic when you're trying to figure out what's going on with your patient. It can affect any demographic, appears immediately or months later, causes new conditions, or worsens existing ones. Clinical course can vary from recovery to permanent disability and is diagnosed clinically, not through biomarkers. So, additionally, a positive COVID test is not required for diagnosis. If you have a patient who's, was ill, was exposed to COVID, now they have symptoms of long COVID, it's okay to diagnose long COVID. don't exclude them because they may miss out on things that are offered to them. Programs and services may be lost because of the lack of the diagnosis. What are the risk factors for pediatric long COVID? As with adults, infection with the pre-Omicron variant, increasing age. There is a sharp increase in prevalence at adolescence. The higher the severity of the acute COVID illness and number of organ systems involved, presence of underlying illness, increased weight status, and repeated infections. This data is from a prospective study. It was conducted at a pediatric post-COVID clinic in Rome, Italy. They included, I think it was around 1,300 children, and they looked at the prevalence of long COVID after an acute infection at multiple time points. And you see at 3 months, 23% prevalence. At 24 months, there was 7% prevalence. They additionally are looking through 36 months, but they didn't have the sample size was too small, and they didn't complete the analysis on that at the point of this paper. But at the time, there were 11 of 47 who still had long COVID. Again, just to point out, it is still present in some at that point. I can tell you, this illness it's a post-infectious illness, just as mono can cause this same post-infectious illness. I see patients in their 50s and 60s who got this in their teens. So it certainly can persist. This information came from a pediatric post-COVID rehab clinic at Johns Hopkins. And what they did is one of the aspects of the study was looking at quality of life. And the overall score was 55. The lower the number, the lower the quality of life. This is indicative of major chronic health conditions, of which long COVID is. Cystic fibrosis and cancer both have similar scores. It also affects physical functioning in a severe way, school functioning in a severe way. You're talking about kids' futures. Their social functioning was better preserved, but still at the level of moderate chronic health condition, which would be something like asthma. So again, quality of life severely infected. This is just a quick graphic. It shows you organ systems that can be involved, symptoms that can be involved. You've probably heard these before, but again, in case you're a newcomer, fatigue, sleep problems, cognitive issues, orthostatic intolerance, GI symptoms are very prevalent, headaches, paresthesias, sometimes pain, just everything all over the board. This slide comes from the NIH-funded Recover Pediatric Study. And what they were doing is they were looking at making research indices. And what that means basically is that when they enroll a child in a long COVID study, they want to make sure that the symptoms that they're attributing to long COVID truly are to long COVID. So it's not that I want you to memorize what symptoms I have listed here, but I want you just to look at who they looked at. They found that infants and toddlers were affected. Preschool-aged children are affected. School-aged children are affected, and adolescents are affected. Every age group, again, as I said before, every demographic can be affected with this illness. Infection-associated chronic conditions are nothing new. They've been present, who knows how long, we don't really know, but described certainly in the 1918-19 flu pandemic. Many infectious agents have been implicated, especially Epstein-Barr, enterovirus, West Nile, Giardia, Borrelia burgdorferi. Then there are a subset of patients who have a more persistent and severe symptoms, and they meet criteria for myalgic encephalomyelitis chronic fatigue syndrome, also known as ME/CFS. What is ME/CFS? Again, we diagnose it clinically because there is no biomarker. The Institute of Medicine in 2015 developed criteria for us to use. I've seen a lot of times people are reticent to make the diagnosis, but it's clear, just here it is. I don't make it quickly, certainly not. If I certainly wait 6 months, I wait the time frame that I need to, but don't be afraid to make the diagnosis. You are qualified to make it based on these criteria. So all major criteria are required for the diagnosis. There must be impairment of normal function. They can't do the things they used to be able to do. This is accompanied by fatigue that is often profound and of new onset. It's not the result of ongoing excessive exertion and not relieved by rest. They must also have post-exertional malaise, and we'll talk more about that. And they must have unrefreshing sleep. Despite adequate duration, sleep doesn't restore energy. They must also have one of the minor criteria, cognitive impairment or orthostatic intolerance. I find in my kids, my pediatric population, they usually have both. Symptoms must be moderate to severe and present 50% of the time. So to kind of summarize where we are, if you get exposed to SARS-CoV-2, you may have an acute illness or you may have an asymptomatic infection. 80 to 90% of the time, symptoms will resolve. 10 to 20% of the time, they're left with long COVID. Of those, again, much of the time, the symptoms resolve and everything is okay. Some have continued symptoms, but they don't meet the ME/CFS criteria, still ill and still need help. And then there are those who developed ME/CFS. In adults, 50% of patients with long COVID meet criteria for ME/CFS. The data is unavailable regarding children of what the rates are. So when do we want to think about it? Again, I kind of feel like it's a really easy if they come in and they had a COVID infection, they were positive and never really got better. Okay, that's certainly sounding like long COVID, but it's not always quite so easy. Think about this whenever you're thinking, when you see a child and you think, oh, I need to think of adrenal insufficiency, I need to think of diabetes, I need to think of narcolepsy. When you're thinking of multi-system symptoms, something serious, think about long COVID as well. Really go back and dig into that history. A few months ago, did your kid have a cold? Did somebody in the family have a cold? Were they exposed? If they're in school, gosh, all bets are off. So new persistent multisystem symptoms, a clear decline in function. It's not just fatigue, remember, it's decline in function. They can't participate in all of the same things that they could before. In teens and school-age children, are they able to do their schoolwork? Are they able to attend? How much school are they missing? Are they, going to school but yet can't do anything social? Younger kids, it's a bit more challenging. Lots of milestones. Failure to thrive, poor feeding, poor appetite. Those, again, you really have to have your radar up. If they have symptoms that worsen after exertion or symptoms that worsen with prolonged standing, if their disease is unpredictable, if their symptoms are, they were fine this afternoon and the next morning they're terrible. They feel terrible and can't go to school. And then they have a couple of good days and a bad day here and there. Also, I kind of call it whack-a-mole. Something new pops up all the time. They were doing good. Their headaches are better, but now their GI system is all in a mess. Symptoms are consistent across settings. In other words, it happens at home, it happens at school. It's not just, I don't want to go to school. It's, I'm on vacation and I'm not going to participate in Disney World because I'm too tired to. We want to do a really good history and physical, as we always do. Our physical should, get that neuro exam in. You want to get a good neuro exam and get a Beighton score, which assesses hypermobility. QR code there, and again at the end, will tell you how to do the Beighton score if you aren't familiar. About 20% of kids with long COVID are felt to be hypermobile. I find that hypermobility is, used to be cute. It's not. It's something that for me confers, additional comorbidity and problems. And so you want to look for that. So there are things you can be proactive about. And also I do my usual lab workup, that I do when I'm looking for other serious illnesses. Especially in this illness, I do get an echo, Holter. I do a lot of sleep studies and event monitors. I have a couple of really good tools. You'll want to, again, download these at the end. The Good Day, Bad Day questionnaire and hours of upright activity. So this really captures that unpredictable nature of ME/CFS and long COVID. I have kids that have seen their pediatricians, they've been to, other doctors, they've gone to, see specialists. And it's sort of surprising to me how someone can have so much dysfunction and the provider, it doesn't reach them. They don't understand it or comprehend it. That's why this tool is so helpful. We ask them, how many good days a month do you have and how many bad days a month do you have? Of course, if it's a teen, they can, fill it out with kids. You're relying on parents, of course. But how many good days? On your good day, what can they do? On a good day, what can they not still do? Maybe they can attend school about three-quarters of the time, or maybe they can go half a day on a good day, but they can't do their homework. Or they can't feed the dog, which was their, used to be their chore. How many bad days are they having? What can they do and not do on a bad day? Also, how many hours of upright activity do they have? So the way we define this is feet on the floor. If you are standing or walking, or if you're sitting with feet on the floor, that counts towards your hours of upright activity in a 24-hour period. Most healthy children is 12 to 16. Many of my patients, 0 to 2, 4 to 6. I don't have really many patients that get to 8 to 12. So, when you see that, if you see hours of upright activity on average is 2, something's wrong. And you really can't ignore that. If you just see the kid for 20 minutes in a visit and they got there and you don't know what happens to them afterward, it would be kind of easy to miss this. So this is a really great questionnaire that the Bateman Horne Center uses. We also have an orthostatic intolerance questionnaire. Again, quick picture. If I see a bunch of X's over here on the right side, I'm looking at orthostatic intolerance. If I have a lot of zeros, then I may need to think about something else. Again, just a list of conditions to consider. You probably already know these, and it's not an exhaustive list, but if you need it for later. I want to turn attention to post-exertional malaise. And those of you who've been listening to our echoes are probably like, oh, we've heard about this a lot, but again, it's vital that we know about post-exertional malaise and we warn our families about this entity. It is defined, or I refer to it as PEM, by the way. So if you hear me say that, that's what I'm talking about. It's defined as an inability to recover normally following exertion. Exertion includes anything that consumes energy. Easy enough, we know riding a bike is physical. That's exertion. We know that. But cognitive exertion, emotional, social, environmental exertion can all induce PEM. A kid has a birthday party, and maybe you have a sedate birthday party. You're doing puzzles. You're not running around, doing a lot of active things. That social excitement, that is energy consuming, and that can lead to PEM. So don't forget about those things that we don't really typically think of as exertion, at least not outside of the ME/CFS world. So PEM results in worsening of symptoms and functional ability. It results in profound fatigue. The pathology of the disease is augmented with worsening autonomic dysfunction, reduced metabolic efficiency, immune dysfunction, and disruption of the HPA axis. It can be immediate, but it's often delayed 12, 72 hours from the exertional stressor. This can certainly make things confusing. Again, a kid rides a bike and on Monday and it's Thursday when they suffer the consequences. That can be daunting to try to explain to parents and to children and to get them to understand that. There's a prolonged recovery out of proportion to this once tolerated trigger. It may take days, weeks, months, or even longer to recover. So how do I ask or screen for PEM? I ask about, one clue is if when you're seeing a patient, especially at the beginning, you might notice that they've been to urgent care or come in several times for feeling like they might have the flu. You may do your typical, let's check for flu, strep, COVID, everything's negative, you got a red throat, swollen glands, you kind of look like you feel really bad, but nothing's really showing up. And then, a month later, they're back. Same thing. A month later, and you're thinking, okay, maybe it's mono. Check mono, it's negative. They may take longer than 24 hours to recover from exertion. Cognitive symptoms. Teens can tell you about that, and really cognitive symptoms, and we'll talk about that next time, but cognitive symptoms are really interesting in children. They don't recognize sometimes that that's what's going on. And so, that's something to ask and try to really dig deep with that one. With kids, with smaller kids, you might see just withdrawal. You might see irritability. They sometimes they seem to look like they're fading. I can see it sometimes I see it in a visit. I just watch them fade. And, say, you go lie down, because a lot of times we're doing telehealth. I'm like, you lay down on the couch. And if you hear us say something that you don't think is right, speak up, but you just lay there and rest while we finish our talk. Push crash cycles. I remember with my child, when I was first trying to figure out what was going on, I kept in my brain, I was using the word crash. We go to Disney World. She wouldn't go. She would stay in the room. We'd come home and then she'd be on the couch for a week after doing nothing. And I kept thinking, it's like she's crashing. Or payback. People will talk about payback. Ask teens, what is it like at the end of the semester when you have to take a week of exams? And they'll look at you and they're like, it's terrible. Well, that's something that I ask them. Are symptoms delayed after the activity? Do they worsen for a few days before getting better? Are there sleep disturbances associated with it? This is what PIM looks like in my brain. This isn't an artwork. It's just something I got off the computer. But I thought it's like everything goes haywire. What the patient experiences is worsening of all of their symptoms. If they have headaches, the headaches get worse. They may have them more frequently. They may develop a new pattern of headaches. Cognition gets worse. Everything, just whatever their normal symptoms are, expect them to get worse. Their OI gets worse. Their orthostatic intolerance gets worse. And then additionally, they often develop new symptoms. I've had it described as being encased in concrete. I had one patient, a teenager, said it felt like he was on the Gravitron ride. I've never ridden that, don't plan to, but apparently it makes you feel like you're glued to your seat or whatever. He said he felt like that. He was glued to the bed. So everything gets worse, new things pop up. So what's causing it? What's happening? Again, there's a whole lecture on this, probably on our website, and there's lots of good videos that Dr. Braden Yeoman and Dr. Cindy Bateman did on PIM, so you can get some more information. But briefly, we've used cardiopulmonary exercise testing. Dr. David Systrom is doing a lot of really cool stuff with invasive CPET testing. What they found is that there is a decrease in peak VO2 in people with ME/CFS, and then in PIM, it's even lower after exercise. They have a lowered anaerobic threshold, so they go from the efficient aerobic metabolism to inefficient anaerobic metabolism. There is decreased uptake of oxygen at the level of the tissues. There is decreased mitochondrial enzyme activity in muscle. There's mitochondrial dysfunction, damage to the muscle during post-exercise malaise. There was a study that involved muscle biopsy, and they had tissue necrosis, muscle necrosis that was seen. Patients have more highly fatigable muscle fibers. So again, this is not just I'm tired. We use that term, but when you think of malaise, think of the inflammatory part of this. What can we do for it? So it's been observed by clinicians that have been in this field for some time that, they made the observation, gee, I have a patient that's always in PIM, they just keep getting worse. It seems like that with repeated episodes or a bad episode, one bad episode can really lower their function. I have seen that as well. I am not as seasoned, in experience, but I have a few patients that I've watched, have a bad episode of PIM, and here we still are a year later. Baseline is not returned. Dr. Leonard Jason developed the energy envelope theory. I don't ever explain this really well, but it's basically that each person has, a unique amount of energy that their mitochondria will produce. And as long as you stay within an envelope, within that energy envelope, things are okay. Once you step outside that envelope, you are going to pay back with post-exertional malaise. So if we can keep you within that envelope, maybe you'll do better. And so he conducted a study, provided a coach to help with pacing. At the end, they looked at those who could and could not pace. Those who were able to pace effectively had improvement in physical functioning and fatigue severity. How do we pace? First of all, for me, with my patients, I want to, first thing I'm going to do is talk about it. We want to talk about it and talk about it some more. It's a really hard concept to understand. Can you think how hard? It's hard for adults to understand pacing. It's hard for adults to, live in their bodies for however many years, and all of a sudden everything's different. All of a sudden, overnight almost, you can't do the same things. There's no predictability. It's difficult to predict. Now let's add this to, you have a kid who, a little harder to understand. Additionally, you have parents trying to understand what their child is feeling. They're not in the body that they're trying to help pace. So it's particularly challenging. So it's something we need to talk about at every visit. You also want to do a lot of education of schools, clubs that they're in. Anybody you can get to listen, talk about post-exertional malaise. When they come to see me, I have modifications because I take this seriously. It's not just for you to do, it's for me to do as well. We do some of the visit, we'll do, here I have them do that good day, bad day questionnaire before they come in. They can, do it a week or so before. Then they, have a break before their visit so they don't have to think of all this off the top of their head while they're in the visit. I have a lamp so they don't have as much bright lighting. I try to remember to talk more softly. I have a zero gravity chair so they can recline when they're in office. We also do a lot of telehealth. Again, all of these things to try to help conserve their energy. Then parents, and then again, school age children, teens, you want to teach them, to take rest breaks. You want to do accommodations at school if they're able to go to school. You want to make sure that they get rest breaks, that they aren't doing PE, that they aren't, maybe limit their screen time. When they come in and do homework, I like them to have a nice, quiet place where they're alone. They can put in earplugs, again, a lamp, no overhead light. Don't have the TV blaring in the background, dogs barking, kids running around, chaotic. You need a quiet, calming environment because all of that is energy. All of that is consuming energy. Let them use what they need, to do their homework. Also, I like for them to recline or get their feet up or wear compression boots. That can be very helpful. You can also teach them about physical signs. Again, sometimes it's you observing the child. As the child gets older, you can help them to learn what to watch for. My heart rate feels like it's fast. It feels like my heart is beating hard. I feel like I need to rest. I'm really tired. I'm getting a headache. Those kind of things are signals to sit down, lie down, get where you can as soon as possible, where you can rest. So what do we do when they are in post-exertional malaise? The same things. You want them to rest, but I get really aggressive with it. A dark room, a cool room, minimize your conversations. It's not the time to talk over a bunch of things. Reduce as much activity as possible. Keep things quiet, soothing. Help them learn breathing techniques and relaxation techniques. Help with sleep management. That's where providers can come in. Advise, bland foods, easily digestible foods are helpful as well. This is just a patient case I wanted to tell you about. This was a 15-year-old. She had a COVID infection and developed ME/CFS. She had a lot of PIM. She really had a hard time. She was very active pre-illness. She was an honor student, was planning on attending college out of state, played on the basketball team, very active, vibrant individual. And it's hard to slow her down. And so she had a lot of episodes of PIM. We eventually had her do a hybrid program with school. She was mostly homeschooled, but she did have certain things that she would have to go in for. And at the end of the semester, she had exams. She didn't want to ask for accommodations. And so she went in. She didn't want to be different. I want to be just, I don't have this disease. I don't want to do this. I don't want to be different. And she goes in. Mom drops her off. She goes to school, sees her friends, sees her teachers, has to think, study, take her test, walk in and out. She's been mostly homebound, so she's walking in and out of school. She had 2 tests on Monday, 2 tests on Tuesday. That afternoon, she said she came home. She said she was really irritable. Mom mentioned that she was really irritable, but otherwise felt okay. Ate dinner with her family, and next day didn't wake up till mid-afternoon. She said, I would have gone to the urgent care. Mom said I would have taken her to urgent care if she had not been so sick that I felt like I couldn't get her there. Patient said, as soon as I sat up in the bed, I felt POTS hit me. I felt my heart racing, felt dizzy. Any upright activity triggered her symptoms. Had a horrible headache, horrible myalgias. She felt like she had a low-grade fever, sore throat, swollen lymph glands, all the things. So we went back and talked about it. Took her, by the way, she was mostly bedbound for 2 weeks, and it took her 2 months to return to baseline. We talked about it, when we talked about what can we do differently. So we have accommodations in place. We've asked for home testing if possible. I'm not sure they're going to approve that, but we asked for at least only one test, maybe every other day. She just can't do the same thing, but we want her involved in school. We want her to be able to go to school. We really need you to help out. Sometimes schools are hard. They just don't understand it, and get to know the school nurse, help her educate, provide information, let them know that it's not just you making this up. I felt sometimes like they think I'm making this all up. So I'd go to the CDC website or wherever and print stuff off from there so they could see that it wasn't just me and my big ideas. So that's PIM. Again, very important. You want to preserve your patient's baseline, especially if you have a pediatric patient. They have a whole life to live. We don't want them, slowly spiraling downward. By the time they're 21, they're severe. So now I want to talk about orthostatic intolerance. And this is a really important topic. If you're seeing patients with long COVID, you have to evaluate for orthostatic intolerance. The Kennedy Krieger Institute did a study of 92 children and adolescents with long COVID, found that 70% met the criteria for an orthostatic condition. In adolescents with ME/CFS, it's almost 100%. I will tell you that all of my patients that I see have orthostatic intolerance. I was trying to think if there was anyone that didn't, but they all do. Orthostatic intolerance is also known as OI. It's referring to a group of conditions that develop when assuming and maintaining an upright posture. This refers to standing, but it can occur with prolonged sitting. I remember getting calls in the middle of the morning, and now in retrospect, I know, oh, my daughter was sitting up all day, or for a couple of hours, and that was enough to make her feel really badly. And so I'd get the call to come pick her up. What's going on? What's the physiology? What happens when we stand up? So normally in a healthy person, gravity will pull 10 to 15% of blood to the lower extremities and the abdomen. This causes a decrease in central blood volume, stroke volume, cardiac output, and a reduction in cerebral blood flow. The normal adaptive response to this is an increase in activity of the sympathetic nervous system. This gives us an increased release of norepi and epinephrine, causes an increase in heart rate, 10 beats or so, increased cardiac contractility, constriction of blood vessels, blood flow goes back to the brain. We never know what happened and continue on about our day. People with orthostatic intolerance are an entirely different situation. They have a larger amount of blood pooling than normal. This may especially occur in people with that hypermobility we mentioned earlier. Many patients have a baseline lowered blood volume, and the vessels just don't respond to catecholamines. This results in the development of symptoms, and some are due to the activation of the sympathetic nervous system. Think about people in flight or fight, palpitations, shortness of breath, anxiety, tremors, sweating. Some kids will come in and they look like they have, they just watched a scary movie. They look like they almost look hypervigilant. I've had patients tell me, I feel like I'm vibrating on the inside. And I'll say, well, I think I see you vibrating on the inside. You can just kind of see it. This autonomic overdrive, very disconcerting for a patient to have to go through. The lack of cerebral blood flow can give you symptoms like fatigue, impaired vision, lightheadedness, syncope, headaches, brain fog, decreased attention, etc. I'm not going to define all of these. Again, they're listed here in the slides, but I do specifically want to mention a couple. One is POTS. We hear so much about POTS, and with teens, I see a lot of POTS. I also see a lot of orthostatic hypotension. But POTS, the definition from 12 to 19 is an increase in heart rate, sustained of 40 beats per minute or more within 10 minutes of standing without a significant drop in blood pressure. Notice 12 to 19. What about 8 to 11? I have a kid my kid, when she was 10, had the worst lean test I'd ever seen. I have ever seen. She had the worst lean test. So, don't think, well, it only starts at 12. It can't happen, or I don't need to treat those patients or do anything for them. That's not okay either. But some committees will use this criteria for lower age groups. And by the way, a great resource is Dr. Peter Rowe has a book on Amazon. And again, I'm not getting royalties or anything like that. I just love this book. And he did a really great job. And if you have any questions about how to treat kids with orthostatic intolerance, it's a fantastic resource. Then I want you to look at the words in red, low orthostatic tolerance. So there are some people who have orthostatic symptoms, but their heart rate or blood pressure changes don't meet that criteria. And there's a study done, again, Dr. Peter Rowe, Van Kampen, and others, and they looked at healthy controls, patients with ME/CFS with POTS, patients with ME/CFS and orthostatic hypotension, and patients with ME/CFS who had symptoms but didn't meet any particular criteria. And they looked at the cerebral blood flow. And what they found is when you do a 70-degree tilt table test, healthy controls have reduced blood flow of about 7%. Patients with ME/CFS and POTS had a reduction in cerebral blood flow volume of 29%. So again, 29%. Those with orthostatic hypotension had a reduction of 26%. And those with the symptoms, but without a defined form of orthostatic intolerance, had 24% reduction of cerebral blood flow. Clearly have problems. Just because they don't meet a certain defined syndrome doesn't mean you shouldn't treat them. So if they're having the symptoms, you want to treat them as well. So just really quick information. This is not an entire patient case. I just want to show you this person's lean test that we did, his passive stand test. He was 13 when and in excellent health. He had no medical issues, normal development, etc. He became ill with COVID-19 in 2021. So this was that pre-Omicron variant. He didn't recover completely. He had, frequent episodes of feeling sick, going to urgent care, fatigue. He had some palpitations and dizziness and just didn't really feel good, kind of limped along, looked like somebody who was getting over the flu. He did this throughout the school year. Then that summer, was feeling a little bit better. His dream was to try out for middle school football. We're in Tennessee, where it reaches about 1,000 degrees and a humidity of 110% in August. And so he goes out for football, and we do it in the mornings and evenings to try to help, but it's still plenty hot, and there's plenty of stress with this. So he does it, and he does it Monday, Tuesday, Wednesday, Thursday, Friday. Goes home on Friday. Mom told me, she said, something was really, really wrong. He went to bed, and he couldn't get up. She said, this is the kid who said, I feel like I'm on a Gravitron ride. He felt glued to the bed. Mom, astutely checked his blood pressure. She's a nurse and saw his blood pressure was quite low, heart rate was high. She started pumping him full of oral fluids and electrolyte solutions. And, it took him about a week before he was able to get out of the bed on a regular-ish basis. He never recovered, though. He never went back to that baseline where he was before. By the time I saw him, he had a WHO of about 2, very limited in what he could do. He mentioned that his feet became purple in the shower. I mean, this kid obviously, looks like he might have orthostatic intolerance. So some of the questions I asked, he's a bit more obvious, right? But have you ever fainted? Do you feel lightheaded when you're standing for more than a few minutes? Do you see stars when you stand up? Ask the parents, do they tuck their feet under them when they're sitting? When you eat at dinner, do they want to bring their feet up into the chair? You're constantly trying to get them to sit right. Do you feel unwell with the hot shower or bath, or if you're out in the hot weather? Those are some of the questions. So this was his orthostatic questionnaire. Again, just look at the skew to the right. I honestly think he's sort of underreported because passive stand test was pretty rough, but these were his scores. So then again, QR code, it'll tell you exactly how to do the passive lean test. It is 100% something you can do. Your nurses can do this. It will require 2, but you can do this. If it's, I know it's hard to tie up a room for 30 minutes, but you might do a separate visit just to come in and get the lean test. So here was his lean test. He had here's the POTS criteria, and then in red, I've told you what he had. So you need a sustained heart rate increase of 40. His was 51 at minute 7. We didn't go further because he was okay with going further and wanted to, but I said, you look too bad. We have to stop. He didn't have a drop in blood pressure. He did have an increase in his diastolic blood pressure, narrowing his pulse pressure. And his pulse pressure index went down to, I think it was 16 or 18%, but numbers you see in the ICU when people are in shock. He had multiple daily symptoms. His symptoms had been present over a year, and there was no alternative explanation like dehydration or infection. So he met criteria for POTS. This is what he looked like at the end of the exam. His feet normally and legs normally look like his mom's finger that is in the right-sided picture. It was the most purple legs I've ever seen. So what do we do? What can we manage? How do we manage him? Again, think back to your pathophysiology of orthostatic intolerance. There is a reduction in intravascular volume, so we want to increase that. We want to take that volume and improve venous return. We do that through increasing vasoconstriction. And we also want to mitigate the effects of that catecholamine release that are pretty miserable for people. So first thing, non-pharmaceutical solutions. Let's avoid the things that can trigger it. Avoid the heat. Take your kids to play early in the day. Talk to your parents about, shopping. If at all possible, don't take them where they have to be in long lines. Accommodations. You can write accommodations for school. Kids in speech class. Can the kid do the speech sitting? Can they have a stool to prop their feet up? Can they go to the nurse's station for breaks as needed or maybe as scheduled? Can they do half days, hybrid days, etc.? Things to avoid the triggers. Avoid a hot shower. If they just love showers, they need to be cooled down. And you can get, if you don't want to use grandma's shower chair, you can always buy, again, I don't receive proceeds from Amazon, but Amazon has these really cute teak stools that kind of look like you're at a spa. So, those are kind of nice. We want to increase their intravascular volume. This can be done with fluids and sodium. In adults, it's easy. I tell them 3 to 4 grams of sodium, 3 to 4 liters of water, unless you have CHF or something like that, right? But in kids, it's different. You may have an 80 pound, 10-year-old, and you may have a, strapping teenager that's 180 pounds. So it's a big difference. So what I do is I kind of see where you are now. What are you consuming? And let's start to increase it slowly. And let's find your spot. Where is the spot that makes you feel good? Where's the spot that makes you feel a little bit better without having nausea or feeling bloated, etc.? So we just start slow and work our way up. There's lots of different ways to do it. Some people, I like the electrolyte solutions and I like them in the liquid. I think it absorbs better and you can measure it and you know what they've consumed. If that's just they don't like it and won't do it, you can always put salt on their food, but what happens if they don't finish their meal? But again, whatever you can do to increase the salt consumption and the fluid consumption, and they have to go hand in hand. If all they do is increase their water, they're just going to go to the bathroom an awful lot. We also want to maintain that intravascular volume. Compression is good for that. 20 to 30 millimeters of mercury, optimal full waist leg compression, then abdominal binder and compression socks in order of efficacy. It's hard to get kids to do this, especially in the summer, but try to encourage this. Volume expanders. Fludrocortisone, it's a mineral corticoid, increases water and sodium retention. Doesn't work if they aren't drinking sodium and water or consuming sodium and water. You have to have something in the vessels for it to be retained, right? It can cause a little bit of vasoconstriction as well, so that's helpful. Of note, about 1 in 20 will develop a depressed mood. If you stop it, it improves. Just be aware of that. Make sure the family and child, when appropriate, is aware of that as well. Sometimes I'll use IV fluids. Sometimes kids are really nauseated, especially early on, and they just can't get the fluids and the salts in. So sometimes I'll give saline. It's not a permanent solution, but it's something that can help get them started and get them to feeling better. Midodrine helps with vasoconstriction. Arterial and venous tone is where it does its effect. It's dosed every 4 hours. I know, cringe, kids, every 4 hours is hard when they're awake or upright. They did studies in elderly people. It can cause supine hypertension, but I apply it to kids as well. Don't take it and lie down flat. Stimulants can be useful. Just be very careful. If you go too high on the dose, sometimes you can end up with a person in PEM, or they think, oh, I have all this energy, and it turns out they really didn't. SSRIs, SNRIs can help with vasoconstriction as well. And then we think about that autonomic overdrive. Beta blockers are great for this. I tell you, patients who have, those patients that are telling me they're vibrating on the inside, a little bit of a beta blocker, unless there's a contraindication, they really appreciate it. It's a terrible feeling. I don't know if you've ever felt anxious, or that feeling you get after you've almost hit something, you've almost rear-ended somebody. Can't stand that feeling. I think it's terrible, and they go around living like that. So if you can do something for that, that's really helpful. Ivabradine does help reduce heart rate without lowering blood pressure, but it doesn't help the dysautonomia, that sympathetic overdrive. So don't count on it for that. And it can cause visual halos. I'm not giving you all the side effects. I expect you, if you're going to prescribe a drug, be sure and do your due diligence to look up all the things. Pyridostigmine, useful for myasthenia gravis, also useful for OI. It's an acetylcholinesterase inhibitor. It increases parasympathetic activity and reduces heart rate. It can cause cramping and diarrhea and muscle twitching. The muscle twitching isn't harmful, but can be, annoying. And this is one of those drugs that I hear either it's the best thing you've ever given me, or please don't ever give me that again because of the cramping and diarrhea that it can cause. So I start really slow on this as well. And as a rule of thumb, anything I use with children, I start really, really low, just ridiculously low, and slowly work my way up. Sometimes there's a lot of sensitivity to medications, and so it just feels safer to start really low. Clonidine and guanfacine, these are selective alpha-2 adrenergic agonists. They can help with insomnia and attention issues as well as OI. So, which drug when? Some people start with fluids, fludrocortisone, go up the ladder. Depends on the person. For me, my kid, the 13-year-old, We started with fluids. He was a champ at drinking fluids and consuming the sodium. He was really great at that. We added in some fludrocortisone. I tell people you often don't feel a major difference. It's just kind of laying the groundwork for me. I want to get that intravascular volume up, and then I added the midodrine. Now it has something to work with. So then we added midodrine, and this helps relieve some of his symptoms. He didn't feel as, he was able to get to the bathroom, walk around his room a little bit without immediately having to lie down. Didn't cure his POTS for sure, but it definitely helped with quality of life. Then later we added in beta blockers. Those did not do well for him, and then we did pyridostigmine, and that has also been very helpful. Again, two birds with one stone, right? If they have chronic headaches, beta blocker. If they have attention issues or cognitive dysfunction, again, stimulants, but very, very carefully. Clonidine and guanfacine can be helpful for this. Constipation, pyridostigmine. If they have salt craving, fludrocortisone. So next time coming up, I'm going to talk about mast cell activation, cognitive impairment. I think cognitive impairment is super important. I had a patient tell me after seeing her for a couple of years, I asked her I said, how does cognitive impairment feel? And she started telling me about it. And I realized I had just didn't comprehend how bad her cognitive impairment was. Made me really change how I looked at things and changed how I asked the questions. And kids don't understand that. They don't understand that there's a problem. Oftentimes, what she told me was, she said, I felt like I was dumb, and I felt like I couldn't keep up. And this was a really bright, beautiful child, and we don't want kids to feel this way. So tools to help with that. Then we'll also talk about patient cases. There will be less of this, groundwork and more of patient cases, so we can talk about how we can approach the patient.